So I'm going to talk today about a project that I've been working on in South Africa for the last 5 years, but it kind of builds on all of the work that I've been doing the last 5 or 6 years, both our family wellness initiatives here in LA, as well as our randomized controlled trials in South Africa. And if you...
Yeah.
There's a little bit of glare on. Thank you.
And as HIV has become medicalized and the focus has really shifted from community settings to hospitals, you have to wonder what's going to happen and how important does task shifting become when health budgets, there's 52 African countries, 20% of those, 10 countries have a budget of less than $25 per person per year. Remember that HIV drugs are a minimum of $300, and that 2 out of 5 African countries have a healthcare budget of less than $50 per person per year. There's no way that the current healthcare systems of the majority of African countries, there's no African country that meets the global goal of 15% of their gross national product being focused on healthcare delivery. No African country. So unless there's a really significant move to health extenders and to looking at how paraprofessionals are going to involve in this, it's not going to be feasible to reach our goals for HIV prevention. And there's a lot of hope right now. Treatment is prevention is mobilized the Global Donor Agency, and I'm going to focus on South Africa today. 2 out of 6 million HIV-infected persons are on treatment, supposedly. Perinatal coverage is 98%, and HIV transmission from mother to child was 24%. It's now 2% in South Africa. Plus, you have circumcision, which is trying to be scaled. In South Africa, 66% reduction in transmission. There's huge amount of hope, but meanwhile the reality is kind of problematic. Only 1 out of 4 have been tested. But in fact, if you ask people, we did a study last year where we asked all the men in 4 communities, and 75% of them said they had been tested in their lifetime, but it doesn't jive with the data. If you look at these data, and I'm going to show you some later on perinatal cohorts where we have a 90% follow-up, supposedly 83% are linked to care. That compares with 41% in other parts of Africa. 62% supposedly in South Africa. 62% of those 2 million on treatment have viral suppression. I would greatly doubt these data based on our experience. And it's overall 25% in sub-Saharan Africa. And 71% of South African patients are seen as being adherent, where it's a little higher in the rest of Africa. It suggests that the treatment cascade is potentially efficacious if you look at those data, but the on-the-ground data aren't jiving. It's similar, did anybody see the New York Times this weekend? They had a bunch of articles on sex. And so by person self-report, there's 1.8 billion condoms being used in the United States, according to men, 1.3 billion by women, but in fact there's only 600 million sold. So there's a huge discrepancy, and so you wonder at these rates that are being reported, because they're not based on healthcare delivery data or any kind of valid or health system data that people can go to. Concurrent with all this hope, global donors are moving. And in fact, NCDs, non-communicable diseases, starting in 2012, are the shift, and they're the shift for a lot of good reasons. 87% of the money goes to HIV, 66% of the deaths go to non-communicable diseases. In South Africa, 200,000 people die a year. That's about 40% of the deaths that you would report. 500,000, about 505,000 people die each year in South Africa, and 2 out of 5 of those are for HIV. The rest are non-communicable diseases or injuries. So as behavioral scientists, we set up the criteria a long time ago that our interventions have to be cost effective. Not very many of them are. And in fact, where have we focused our portfolios? On these multiple session, multi-component, cognitive behavioral, skills-focused interventions that are labor-intensive, that if you look in our own country, that the CDC is annually trying to train 2,500 CBOs. Out of those 2,500 CBOs, only half that they train, and they spend several $1,000s for every training, only half of them ever try to implement what they got trained in. Of the 50% who try, only 20% do anything that could imaginably be recognized as the original intervention. And I remember when people went to replicate interventions that I had that were on the CDC's Debbie list, the official first task was that they put a trash can in the middle of the paper, they threw in the manuals, and they lit it on fire. That our current ideas about how we're going to replicate with fidelity and be sustainable don't allow people to evolve over time in what these interventions can or should be. They're rigid, they're manualized, and they're not getting used. So I hit the wrong button. In the American Psychologist a few years ago, I wrote an article with Dallas and Bruce Chortita that basically we need some disruptive innovations more in how we do business for behavioral interventions. Ours are all PI-driven models. And if you look around the country, there are actually 22 evidence-based models that have come out of our group around UCLA that CDC is in the synthesis project, the REP or the Debbies. But in fact, people aren't using them. And everybody, if you look around, there are 14 evidence-based interventions for parenting. And everybody focuses on why my parenting program is better than your parenting program. And I would say 90% of what all parenting programs do is the same. We don't focus on what's similar about what we do, what are really common, a synthesis of what we do. We create these manuals that are unresponsive to context, and then we expect people to replicate them with fidelity, and all the evidence is they're not going to do it. Furthermore, almost all of them are female models. That women, if you look at Shelley Taylor, women deal with stress by tending and befriending. If you look at our interventions, it's all about, a lot of them are small group or bonding or psychotherapy models. Psychotherapy models are female models. Men deal with stress by fighting or flight. That was Shelley Taylor's breakthrough, that in fact we didn't realize that all the research that had been on stress had been done with men, but all the interventions that we've created have been based on female models. How are we going to deal with this in creating a new generation of evidence-based interventions, or harvesting from what we do? What are the key foundational structural components, and looking at different ways to diffuse them? The metaphor that I often think about, and I bet I skipped some things, is that prevention scientists are kind of like custom house builders. And you know, my program is better than yours, it is better, they're all different, but in fact, they all have a structure. They all have certain processes, and their content might differ, but there are foundational skills that Dallas, myself, and a couple other people have done a series of 4 or 5 articles that when you analyze what's in the manuals, that you find that there are very similar processes across all evidence-based interventions. Everybody's active, everybody's goal-oriented. They must reiterate the idea that there's a goal for every 10 minutes, for the session, for every 10-minute segment, there's a deliverable. Very much like even if you're a custom house builder, every house has a foundation, every house has a wall, every house has a roof. So that we think we're unique, but in a way, having all these custom houses overserves the need. To have 14 different evidence-based interventions on parenting, we don't need 14 different ones. What we need to be clear is what's important about parenting and what's the most cost efficient. So what we've been advocating is that rather than being custom architects, that if we wanted to take care of housing needs, we'd be better to be building tract housing. And in fact, disruptive interventions are cheaper ways that try to meet the needs of most people, while those with very high-end needs we're not going to meet. But if some of you are old enough to remember when you had to go to the bank to get money, not to an ATM. And so an ATM meets 80% of your banking needs and decreases cost. 80% of our eyeglass needs can be met by $2 eyeglasses. I bet every person in this room paid more than $200. But in the overall world, it could be met by $2. So how could we begin to think about our evidence-based interventions with a different set of norms? So what we've been doing for about the last 9 years here, and if you look at mental health literature, Bruce Cherpita, who actually is at UCLA, has scored the manuals of 1,000 evidence-based interventions for mental health for children and families. 14 skills are in 80% of those 1,000 manuals, 14 skills. Now our group took the 14 and we went down to 11. And so what we say is, and what you're going to see today are the results of, rather than only training on a manual, could we train everybody on the foundation? This is our little house. And the foundation is the skills that are common to every evidence-based intervention: goal setting, relaxation, problem solving, assertiveness. Dallas will have to tell you the rest. Self-monitoring. And there are common principles. Like if you looked at all of our adolescent evidence-based HIV interventions, every one of them gives a message to be prepared. Now, for be prepared, what it might mean tonight, what it might mean today is PrEP, or pills for post-exposure prophylaxis. What it meant 20 years ago were condoms. What it means if it's obesity prevention is have some carrots in your house and some fruit. That you're prepared is common across multiple domains. And actually, we identified 10 principles that were common across every adolescent HIV intervention. Another one would be act on what you know, not on your feelings. Another one would be, Dallas, do you remember?
Distinguish myth from fact.
Distinguish myth from fact. But they're like habits of daily living, similar to everything I learned in kindergarten. It's a way to try to harvest what's common across our existing evidence-based interventions. So we train really well on the foundational skills, and then we'd say the content areas are going to differ. South Africa right now, HIV has been siloed and vertically integrated. You go to an HIV testing site, then you go to an HIV clinic, then you're on an HIV ward. It's no longer going to go that way. And for community health workers, you're going to need horizontally integrated programs. So if you look in South Africa, fetal alcohol syndrome, highest rate in the world, between 6.5 and 9.5% documented. Malnutrition, 17% low birth weight, 24% malnourished kids. Plus HIV, about 30%. So if we only focused on HIV, first of all, it's going to be stigmatized, and a community health worker is not going to be able to address it because nobody wants to talk about HIV. So that if we can enter through other less stigmatizing issues, we're more likely to sustain. And a community health worker in this country probably, do people know about the nurse home visiting partnership, nurse family partnership by David Olds? It's got the best evidence-based outcome data. It's low-income mothers visited by a nurse, and 15 years later, these kids are doing better. They do better all the way along. They're less likely to be in jail. They're smarter. they're healthier, their parents are healthier. And 25 years after David initiated it, he initiated it in 1976. There have been at least 3 or 4 randomized controlled trials. He got a $15 billion set aside in healthcare reform. There are 22,000 women each day in the United States visited by nurses. There are 17 million low-income women who need visits by nurse-family partnership. That's not going to be replicable here. And what nurses are going to need to do in LA are going to be about obesity and maybe alcohol, depending on the group. But what nurses are going to need to do in the South is going to be a different topic. And so we would say the walls of this house vary by the domain. In Uganda, it's going to be malaria and HIV. In South Africa, it's going to be alcohol, HIV, and malnutrition. But there are predictable situations and predictable developmental patterns. But what we look at in manuals is that every single manual on whatever your topic is, whether it's malnutrition, HIV, or alcohol, you better frame the issue. There's a few bits of knowledge, but the knowledge is useless unless you can use these behavioral foundational skills to apply it to your life. You have to remove the barriers and build a support system. And then we're going to allow a lot of cultural adaptation. You can do it your way. And you better anticipate that there's going to be crises, and we're not going to make you do it on the basis of my manual that I write that you're then going to have to say word for word in the field. Uh-oh, I did it wrong again. So globally, there's 4 million community health workers every day. In Pakistan, they're working on depression. In India, they're also working on depression and mental health issues. Ours were about malnutrition, fetal alcohol syndrome, and HIV. Oh gosh, I'm sorry. And that's a picture right next to one of the neighborhoods that we worked in. And we are working with a community-based agency that was founded in 1979. So I got to, their donor is Desmond Tutu. I got to go to his house and have dinner with him, and he's really funny. But why this organization? We had a parallel randomized controlled trial at the same time. Clinic-based community health workers, they only hit 50% of the target women, and the follow-up rate was 26% at one year. This organization had accountability built in from day one. And that's a big issue in South Africa, because as apartheid ended and unions came in and there were more jobs, there's a tendency not to be able to hold people accountable. They visit all homes in a neighborhood, not just where people have problems and that we should improve. Their primary goal is to connect or engage with families. They had huge community ties and a communal kind of decision-making process. They weren't very good, though, on behavior change theory. They were really great at connecting and holding people accountable. So they call their community health workers mentor mothers. And they were different in how they selected, how they trained, and how they monitored. So they pick positive peer deviance. Tell me the women whose children are thriving. I'm going to hire them. Because they have to have the pragmatic skills of day-to-day life. So part of the interviewing procedure is go to their house. Is it organized or not? Doesn't have to be rich, but is it organized? Second, how are you going to train them? They used our training model. And third, accountability. There has to be a log. And so they had been using paper logs since 1979. We moved it to mobile phones. Mobile phones permeated all of what we did. This independent assessment team collected the data on mobile phones. I could sit in LA and watch the community health workers visiting the household, so I knew if someone was trying to make up data or not. It's on a global consult. And then the mentor mother data was all fed to supervisors who got to track and who reviewed their charts on a weekly basis, and they had ongoing service. In the United States, there's parallel efforts to the nurse home family partnership, They have a huge number of 6 big statewide experiments going on. The average amount of training they give their community health workers is 1 week. We estimate it takes 9 months with somebody being in the field to create a good mentor mother. And mobile phones helped everybody, but here's the entree strategy, a scale. Not about HIV, it's a way, it's concrete, you strip the baby, you weigh them, and you can chart their weight to know whether they're malnourished or not. Then that opens up a conversation. So, randomized controlled trial, we're now doing the 5-year assessment. I'm going to present the data up to 3 years today. So this is going to be a really critical thing. Our target was 4 antenatal and 4 postnatal visits. We had about 8 visits here, about 15 visits here, but then they drop off. And you'll be able to see in a little bit what happens to the data when the visits drop off. Really, really high retention. Out of 5 assessments, up to 3 years, baseline, post-birth within 2 weeks, 90% were done within 2 weeks, 6 months, 18, and 36 months. 80% did all 5 assessments, 91% got 4 of the 5, 98% we got at least 2. So we lost 1.2% after the baseline. Not bad for South Africa. No follow-up point went below 83%. We had really good community matching, 12 matched pairs, 24 neighborhoods. The number of bars, we used aerial maps on the size, the density, because you have both formal built houses and little shacks. Do you have water on the premises, or do you use a communal pump? What's the rate of HIV? And then we did street intercept surveys with 20 women on the weekend. How long had you lived in the neighborhood, so we could make sure we didn't confound by neighborhood migration. And randomization worked. UCLA, Scott did the randomization. Age, they were about 26 years old. They had about a 10th grade education. 80% had never graduated from high school. Their income was definitely less than 1,000 Rand per month, which means $100. 1/3 had a previous child. 17% had a previous low birth weight baby. It's 29% overall were HIV positive to begin with. And almost everybody had a partner, but only 50% lived with their partner. So you're pregnant, but half live with your partner. So let's look first at mothers living with HIV positive and HIV negative moms. And you can look that this is during pregnancy. More than 30% were drinking alcohol. So, and HIV negative moms were less likely. Audit greater than 2 means you've got withdrawal problems. And so,
I think every time you touch the screen, it changes.
oh, you touch the screen. Oh. Okay, so this means that 25%, if you were drinking, you were somebody who had a problem with alcohol. And mothers with HIV were more depressed. This is like while you're pregnant than non-HIV positive mothers. But let's look at our data about length of care. Really, really high perinatally, 83.5%. If you're HIV positive, you're getting AZT for 6 weeks. It was a dual regimen when we were going. Your AZT, you get nevirapine in labor. You'll see the data about how many adhered to PMTCT in a minute. But these are really disturbing to me, and they don't match the national data. And we have really high follow-up, and we got 98% of all pregnant women in those 24 neighborhoods. So we have high internal and external validity. 6 months later, you have your antenatal clinic for being HIV positive. You go in your regular antenatal. Then you have to move to an HIV clinic. Fewer than half went to that HIV clinic. If you did, most of them got ARVs. 18 months, your kid is 18 months old, it's a little more than half have gone to an HIV clinic. 3 years, 2/3. But the real kicker,
That's ever gone, or is it?
they reinitiated care.
Okay.
So everybody's 90, in Cape Town, 99% got tested. And you'll see, I'll show you the PMTCT in a few minutes, intervention and control, but really great perinatal adherence. But then you have to shift to another clinic. Fewer than half are doing it. A year later, a little more than half, still 1/3 not re-engaged. And here, between here and here, is 15% new. And consistent at 6, 18, and 36 months, 1 out of 3. Doesn't match the national data on their national statistics. These are the most distressing. Antenatal, these are on the control group only. Antenatal infection rate in the control group was 32%. Overall, it was 29. At 36 months, we have 5% more. Now, it could be they chose not to disclose, but there were only 7 at 6 months who became newly infected. These women are becoming infected in the next 3 years while they're not going to the HIV clinic, and the intervention didn't work on this. 35 of 140 HIV-positive women in the control group are dead. And infant mortality is 8.9%. So, okay, I bet I missed some, okay. HIV-positive mothers, how do their kids look? So they look worse in terms of height for age, Z-scores at 18 months. They look a little worse for weight for age, height for age, and treated in clinic for a high fever. I'm sorry, these are not HIV positive and negative. This slide is out of order. This shows the intervention group is doing better than the control group, kids of HIV positive mother. They're less likely to be malnourished, they're less likely to be stunted, they're less likely to be treated in clinic for a high fever. But we're going to see in a minute, these trends are, the significant differences are here, but if you look at the overall picture, it looks worse. So did the intervention work? These are the PMTCT data. So it had a little bit of effect on each thing, but overall, it has a 50% hit improvement in adherence. So if we looked at, AZT during labor, AZT and nevirapine, we're looking across at every single task. There are 6 different tasks that you have to accomplish to do all the PMTCT tasks. So fewer mothers do each thing. But if you look at the overall cumulative, 44% of the intervention versus 29% of the control group adhered to all the PMTC tasks. Low birth weight infants, the control group had more than the intervention group. If it was your first baby, or if it was you already had a low birth weight infant, where the probability is higher that you're going to reoccur. And those were significant differences. The only difference that we had, Mary O'Connor was our collaborator on alcohol, and in this country, she has an evidence-based intervention that shows you can reduce alcohol during pregnancy. And it worked in South Africa, but it didn't work after that. So we could reduce alcohol use during pregnancy, but then everybody started drinking again. Pretty much, you see it a little bit lower. We could probably play around with the data and say that the intervention's doing better, but it's not significantly better. It only is significantly better in pregnancy. And these women that are drinking in the control group double their drinking by the time the baby is born. And the women in the intervention group that remain drinking reduce the amount that they are drinking, even though they continue. This is actually the same slide. I'm sorry, I should have. These are the 3-year, 18 and 3-year cognitive measures. So at 18 months, we have no significant difference. But what I'm going to show you in a minute is the story on depression. So this is the Bailey, which is a classic IQ score, and that had been adapted for South Africa. And basically, this shows you how many were below 85, which means developmentally delayed. And so there's a 3% difference, not significantly different. These are the measures at 36 months. We used a very fancy, culturally free measure from Clancy Blair in New York. This is the Peabody Picture Vocabulary Test. Now, this doesn't look significant, and it's not really a percentage score, but in fact, at 3 years, the intervention group has better vocabulary, significantly better vocabulary than the control group. But a big part of this outcome is about depression. So you see regression towards the mean, and we didn't train mentor mothers to deal with depression. We focused on malnutrition, HIV, and alcohol. This is a significant difference at 3 years. And it's also significant if you look at what percentage have an Edinburgh perinatal depression score. And we also have the same effect on the Hopkins measure of depression, or there's another measure of depression that we use that I don't remember. But basically, this intervention group looks the same on depression until 3 years. And all of a sudden, they're not depressed. But the biggest story is about the kids of depressed mothers. Antenatal depression is consistently bad for kids, and depressed mothers make screwed up kids, physically, cognitively, and emotionally. And here's just the 6-month data that we started seeing the story when you compare severely depressed mothers. These are not about the intervention and control, that if your mother's depressed, the Z-scores, your weight is better if your mother's not depressed on a baby. These are the first 18 months data. This is the control group for mothers of depressed, and this is whether they're stunted or not. So mothers of depressed kids start out half a standard deviation below the World Health Organization Z-scores, and they get worse and they stay bad over time. If your mother's antenatally depressed, you're stunted out here, you're heading towards stunting. Your height for age Z-score is low. The intervention group are right up here with the non-depressed. So depressed women in the intervention were just as depressed. They didn't stop being depressed, but they cared for their babies better. So they weren't stunted. Antenatally depressed, did your child have a cough in the last 2 weeks? In the intervention group, about 15% difference, or more than that. Half as likely to be admitted to the hospital among intervention depressed moms compared to that. You're feeding. Did you breastfeed for the first 6 months? The rate in South Africa is 3%. And in large multi-country trials, South Africa was consistently the failure country. You couldn't increase breastfeeding. So we did well. Overall, we got 12% in the intervention. That's good. But depressed moms, 9%, compared to control of 2.7% for 6 months. The number of months exclusively breastfeeding on average was, again, significantly better. And did you give them a bunch of other food? No. These are the depressing data, most depressing. So this intervention group does really well because we had phone data. The average number of a length of time of visit was 31. We knew how often, the spacing, the content of the visit, and whether they thought they had a contact because we have phone data monitoring. And while the mentor mothers are visiting, it's significantly better. It's even better to 18 months. This is the entire group. It's about a 1.3 standard deviations below the WHO mean. On average, these kids are unbelievably stunted. And it really suggests that if you don't keep visiting, you lose it all. The big global mantra now is the first 1,000 days of life. This would suggest these mentor mothers really visited up to 6 months, and then they checked in first for the next 6 months, supposedly every 2 months, but it was actually less common than that, and then every 6 months after that. Nina?
Is it also partly a resource issue? I mean, especially if the nutritional needs increase, do the mothers have enough
Money?
money to feed the kids? I mean,
Actually,
it can't be solved by a mother.
2 out of 5 families have food insecurity issues. If you don't give to your neighbors when you have, you don't get from your neighbors. If there's not communal sharing, there will be problems. And this is the same thing. How many are below 2 standard deviations, which is malnourished, or in this case, it's stunted? And you find a huge increase between 18 months and 36 months post-birth. So that, especially as visits, but the entire culture, 3-year-olds are really in significantly more trouble than the kids are earlier on.
Can I ask you a question? Just, I mean, I'm not an interventionist, but the pattern seems to look like the control and the intervention groups are
Pretty
following the
similar.
same pattern.
Yep, I
And
agree.
the difference that you're making is a slight increase over a pattern that's going on anyway. Was the goal to cause to have a different outcome, a different pattern, or was it just to change that pattern that you knew that was already there?
We would have liked to have a bigger impact. We can say, we did a fancy statistical analysis because we wanted to hit multiple outcomes. So,
But like, for example, there's a dip at 18 months. So, I mean, I don't know if you had this kind of data ahead of time, so you would have known, but would it have been, rather than to get to a different place at the end, would it have been
you
to
would have
avoid
hoped,
the dip? Yeah.
no, you would have hoped to, but in fact, no, these data aren't available.
Right, so you didn't know.
They're
that
very,
pattern.
we didn't know.
Right.
But it suggests, and you can see that the intervention has an effect, but overall, especially on weight for age, height for age, weight for height for age problems. You can see improvements in condom use. And if we did a fancy test, like how many comparisons did we make? The 6-month data was published in AIDS. The 18-month data was in PLOS One. The 36-month data has 4 articles. AJ, American Journal of Preventive Medicine, is the structural equation modeling. It's in revision. The others are out under review. But basically, if you did these fancy statistical tests for how many comparisons, how many did you have to beat at 6 and at 18 months, it was significantly better. But by 18 months, the impact of this early intervention was being reduced. Where did we think the biggest impact was on the depressed moms. And there are these like sleeper effects that we think this Polanyi is likely to be one of the best. And there have been 4 reviews of all these community health worker interventions. You get really efficacious interventions in small randomized controlled trials, most of whom wouldn't have followed to 3 years. Think of all the perinatal trials. The dropout rates are about 75% by 6 months. So there are very few perinatal cohorts that have been followed for 5 years. So all these community health worker interventions, I would argue, are reinventing the wheel, and we haven't been doing a very good job. And we focus on everybody having their own little program, rather than how are we going to implement or scale these things to make them more efficacious. And so I can look at Polanyi and know, especially from seeing the Pakistani programs, the Indian programs of Vikram Patel, there's lots of them in every country. There have been 3 reviews in the last 2 years, 1 in Lancet on community health workers. But we would say, we know, like, how does Polanyi assign people? You have to have a caseload of 40. Now, how does the state, the country of South Africa, assign a caseload? First of all, it's always for a single target, which isn't going to work. So you can be a community health worker for a child grant, and all they have to do is contact 9 people. Whether 9 people sign up for the child grant is not part of the accountability in South Africa. So most community health worker programs, many are unpaid. That's a non-starter. All the data show you have to pay people. Almost all of them are single targeted outcomes, which means that you're not going to get anywhere because these problems are interrelated and complex. All of them train on manuals and try to get people to replicate with fidelity, even to the level of scripts, which we would say is never going to work. Almost all of them are interpersonal. We think mobile phones, you should supplement whatever you're doing with text messages. And now the penetration rate in low-income countries is well over 100%. It's 160% in South Africa, so people have more than one phone. Coverage is good, so that there should be phone and in-person context. And it's never good. Community health worker perinatal interventions are never going to work with focusing on the first pregnancy and the first 6 months of life. There might be a few sleeper effects, but it's just as Pamina said, we didn't change the trajectory. We could have short-term impact. It's good that you don't have alcohol drinking during pregnancy. It's really good that your mother wasn't depressed, that you were breastfed longer. We're unsure, maybe it's because you had a healthier, heavier kid earlier on that you're not depressed now. Why at 3 years? So we have some effects, but they're modest. But if we want to change what's happening for maternal and child health, we got to dramatically change how we do our business. And we would say, synthesize from our existing evidence-based interventions. I'm on an IOM committee now for children's cognitive, affective, and behavioral health. And I organized the second workshop of this committee, because basically we haven't harvested the knowledge. We've done hundreds of evidence-based interventions. Everybody's with the mantra of mine's better. And we're not harvesting what we know from what we've done. We have to experiment much more than we have with different delivery formats. We need market strategies to diffuse what we're doing. Love Life might have failed, but they did a lot of things right in South Africa. And we have to adopt a continuous quality improvement, not replication with fidelity. Not incidental is what about men? So we're newly funded as well. We've done a pilot for several years. We forget these talking to men. We're doing soccer in collaboration with FICA and delivering HIV prevention on the soccer field. Forget this, sit down in small groups and talk. We're training coaches how to coach, cognitive behavioral coaches with those foundational skills. We're funded by NIDA, newly funded. They say the check is in the mail. But we don't think it can be in women's settings and around women's norms. That it has to be where families work and play, and I'll end there for the Palani Plus team. Pamina, you had a question?
I have a question. So maybe I'm confused, but if you go back and look at it again, something that struck me was, so is it 18 months follow-up so that the issue is now that you're looking at the difference in 3-year-olds, or you're looking at a new cohort of babies?
No, these are all,
These are kids that...
these are kids we followed longitudinally.
Okay, so then it seems to me that it's a different set of challenges that people face keeping 3-year-olds
Healthy
than it is babies. And that the types of things that you need to do for mothers with toddlers, where it's about feeding them, whereas opposed to babies, you know, they're...
Reading to them, or...
Yeah, they're just a whole different set, that maybe it's that the effects that you had worked better in a certain age group than it did in the other, rather it being over time. I don't know, it just struck me that those people with the issues for 3-year-olds are different than the issues for babies, and the things that mothers face as a challenge with babies is different than the challenge.
I think you're totally right. That's why we would advocate that if you don't fund for home visiting, or minimum the first 1,000 days, but I would go for community development, ongoing home visiting, and the creation of self-help care groups. You know, the way Alcoholics Anonymous might have, but it's not for people with problems. It would be for our community's care groups in kind of a community development model. But I think you're absolutely right. So we have a lot of ancillary studies around this that support what you're saying. So what do mothers think? The most important time for parenting is during the teenage years. That's what these mothers believe. And as soon as these kids are mobile, they're outside and they're on their own. They care for each other in the streets. I'm sorry, that mothers think that?
Yes.
I think that might not be different in this country, I don't know, but it certainly is true in South Africa. And once kids are mobile, they're on their own. They're outside playing. You see little kids outside.
But being mobile means they need a different type of attention, you know, and that's where issues around shoes, are they wearing shoes?
They're not wearing shoes.
Are they clean, or, you know, that there are different things that affect their health than they do for babies that aren't moving, you know, that are under the constant care. Once they, doesn't mean that they don't need attention when they're 3 and running around, but they need different attention.
I agree with you
So that's
100%.
It just is hard to see that one model, one program would work through that period in the same way.
But I think that home visiting and care groups
Yeah.
would work.
Well,
But then you'd have to train people about, like, they had a very simple, we did a pilot on a very simple book sharing project, had huge impact. Also, the vocabulary differences didn't look very big here, but the scale isn't. My daughter gave me a tutorial on the Peabody Picture Vocabulary Test that, in fact, a significant difference means a lot at 3. So these kids are doing better on some measures, but I would argue perinatal home, it helps. It's going to help in some ways, but if you don't sustain that home visiting among mothers who believe they're not important, you're not going to sustain those effects. Steve?
So, are you making a distinction in here between postpartum depression and just regular depression?
We actually have looked, Erin Sandal has done these, we just got these data in early January. So the depression that we're looking at now is antenatal depression, which is sustained and has impact 3 years later. But in fact, there's only a very small percentage, and then there's 2 levels of depression. So the EPDS cutoff is 13, but probably there's data that looks, an EPDS cutoff of 18 is almost guaranteed to be clinical depression. And so if you look at the outcomes for antenatal depression for women with 18, only about 4% are consistently depressed over time. And in fact, depression, multiple time points is limited to about 36%. And so most people are depressed, not depressed, depressed, not depressed. So those are very complex patterns over 5 assessments. We actually only have data on depression at 4 of the 5. But we're doing the 6th assessment. They've done half the cohort for the 5-year assessment right now. So we're looking at much more complex patterns of depression. Antenatal only, antenatal post at least one postnatal, consistently depressed are the 3 patterns that we're looking at.
So do the women make a distinction between them in their culture? Do they understand the difference between somebody who can't get out of bed, who's really depressed like that, versus somebody who's just really bad?
No.
Oh.
There are women who are severely depressed, and there is a child welfare system, and both assessment interviewers and mentor mothers there have been women hospitalized. But the other kind, what seems really impressive to me, 5% of pregnant women who went through PMTCT plus had this intervention are now newly infected.
That's why it would be interesting to see the effects within conditions, you know, like Did it work differently for women who didn't have a regular partner? Did it work differently for, you know what I mean, like those, once you divide.
So
those
what's
groups
been
up-
real, to me, what was very surprising in this, everybody has a partner. Everybody has a partner, but only half of them ever live with that partner, and those partners rotate out about every 3 months. So that in any one time, 90% of women, and it's similar across HIV positive and HIV negative women.
But I would think that you would see differential effects of a program like home visiting depending on the partner situation. you
Also
know?
maybe depending on number of kids in the household.
Yeah, and the number of,
But with regard to the partner situation, it could play either way, because a lot of women don't want to be with a partner,
right,
because
partner's not good.
Not good,
so-
no.
But so in those situations, maybe, you know, they're more isolated, maybe they want, a home visitor would benefit them more, and then the families where there is a regular partner, you know, I think that these.
Intimate
are
partner
very-
violence, IPV, that's the article at American Journal of Preventive Medicine. We looked at alcohol, partner violence, and depression over time. Partner violence, almost nobody who had ever experienced partner violence did not sustain partner violence over time. What we haven't looked at yet is whether it's the same partner or new partners. But it was a very high base rate, and it was very consistent over time.
See, I think, my reaction was, you're working in a really difficult environment. Women who are very poor, living in a rough place, under rough conditions, a lot of food insecurity. It's a lot that anything happened is amazing. I mean, that's sort of the way I would look at it. So any results that you get where there's an improvement, especially between intervention controls, that's positive. And the fact that it didn't last when the visits tailor up, again, that's not surprising, given just the daily difficulties that people have to deal with to make it.
Yeah. I was thinking the same thing, and kind of brings me back to Nina's point about kind of the income and food insecurity issues, and comparing to nurse home visiting program here that has this sort of inoculative effect. So what's the kind of exposure for nurse family partnership?
It's 2 years, 22 visits.
Okay, so that's
So-
more intensive than the home visiting, and a higher level of training of the interventionists. But also the structural conditions here are much more favorable to be able to kind of realize the skills and the benefits that that intervention then provides. Whereas in this context in South Africa, the food insecurity and the harsh conditions can really suppress any benefits that may have been able to be seen here.
I agree. I think
Combination
that
of factors.
In terms of engagement, Mary Jane, for the project you used like mobile like platforms quite a bit for data monitoring and all those. So, do you have any thoughts about kind of continuing the engagement through mobile phones?
So this program is being taken global. It's in Ethiopia, Swaziland, and one other country, I always get it wrong, by the Church of Sweden. Our Rockefeller Foundation is funding a franchise throughout South Africa. It's we're working in a rural part of South Africa. It's on the Eastern Cape. It's called Zitulele. Some of you have seen. It's like one hospital, 8 clinics, 150,000 people. Like if you don't bring your food with you, you're not eating. It's 150 kilometers north of Port Elizabeth, and then 150 kilometers on dirt roads to the ocean. And I'll say, we've been working with this program for about 6 years. It was written up in Lancet, Zitulele Hospital, and we'll probably bring in Carl LaRue, who's a mentor-mother program like this has started. We have a year's data on a cohort of 500 families. There are 78 mentor mothers walking around in rural South Africa. They influence malnutrition and alcohol at 1 year. But so these things are going on, and it is being diffused, because if you've had experience with community health worker programs, Gates has gone there, totally impressed. So when you go to look at it, it's working. Gene Washington, did he mention, loved it. He went on a home visit.
Oh, yeah, he thought it was
And these are, the mentor mothers themselves, remember, have a 10th grade education. They're coastal women from the community with their own, this is their first job ever. They all drink Coke, 2 liters of Coke. That's the drink. They're all obese.
They stop you drinking Coke.
66% obesity among women in South Africa, 33% among men. Arlene?
So you targeted this intervention to people who were, women who were pregnant and then followed them over time. Did you look for any spillover effects into their other children?
So actually, Ingrid was reviewing that paper this morning. It's taken us 2 years to get it out, but we went back in, we were funded by a local foundation, and we went back in, we looked at all kids in the neighborhood. When our cohort was about 18 months old, we recruited the cohort within 9 months. So there were 9 months, kids, new babies, 9 months younger, and there were kids up to age 6 years of age. And so we did a cross-section with everybody and got every household, and it was Stellenbosch who did it, an independent source. And so what you found was a 1.8 standard deviation improvement in the weight, all the malnutrition outcomes in the intervention neighborhoods compared to the control. So overall, there is a community effect. The other thing that would have dampened the effect here is that they went out and got new mentor mothers for this project. I would have said, if you really wanted an evaluation, you take mentor mothers who've been out there and you monitor what, because we mounted this as an effectiveness study. Polanyi was in charge of the interventions, Stellenbosch was in charge of the assessment. We did the data and the randomization. I did train with them, but I think their program would have had better effects if they weren't trying to mount a randomized controlled trial with new mentor mothers who had never been there before. And the phone, this was like 8 years ago. It wasn't so great with phones then. It's different today.